Dear colleagues, it's a great pleasure for me to talk to you today, and I would like to thank also the organizers for giving me the opportunity to share some of our experience in the treatment of diabetic foot syndrome from Germany with you. And I would also be very happy to get at the end of the presentation some questions from you. These are my disclosures. And let me tell you some words about our hospital. The Asklepios Clinic Birkenwerder is located around 25 kilometers away from Berlin. And we are a quite small hospital, but we are specialized. And our hospital is built from 3 units: the diabetes unit on one hand, the vascular surgery unit, and also the orthopedy unit. And looking at the data of the diabetes unit in 2019, this is the year before Corona, we treated 760 patients with diabetic foot syndrome in the hospital during this year. On an outpatient unit basis, we saw around 2 to 3 times more patients. And from the patients that were admitted to our hospital, 14 cases, it's 1.8%, had in the end a major amputation. The minor amputation in our clinic 2019 were only 9.2% of all hospitalized patients. And if we look at the development of amputations in our clinic during the last around 15 years, you can see that minor amputation decreased from over 20% of hospitalized patients to below 10%. And also the major amputations were decreased in our clinic from around 7% to below 2%. And this is a quite good development that we reached during the last years. And one of the explanations maybe why it is so is the fact that we try to avoid from the very beginning a surgical intervention and bigger operations. And what we do is a minimal invasive treatment of patients with diabetic foot syndrome and osteomyelitis. And what we actually do, we use some, as soon as we found out that the patient has an osteomyelitis, as you can see here on the first toe, we use some sharp instruments in order to get the bone out that is infected and consists of osteomyelitis. And I prepared a small film for you. This is how we try over several days to get out those parts of the bones that are infected. And the principle is that you will never scratch a healthy bone. You cannot get pieces of a healthy bone out with such instruments. What you get out is just that piece of the bone that has osteomyelitis. And we repeat this procedure for several days until the entire ill bone is out. When we have a patient with a diabetic foot syndrome, we have to address at least 3 major problems. The first question is, does the patient has an osteomyelitis? And here the probe to bone test is for us the most important one. If you reach to the bone, then you probably have an osteomyelitis. Of course, we always do also an X-ray, and in some cases we also perform a CT or an MRI. The second question is, which antibiotic should I use? And usually we start blindly. After a few days, we get the results of the microbiological investigation and also the antibiogram from the bone sample that we have sent to the laboratory. And according to this, we then eventually change the antibiotic treatment. And the third question is, how is the vascularization of our patients? We just start with this minimal invasive treatment only if patients have a good vascularization. For this, we look at the pulses. If the pulses are clinically okay, then we start with the treatment. Otherwise, we start with different investigation and we escalate over Doppler, vascular ultrasound, angiography, which quite a lot of patients in our clinic receive. And afterwards, the colleagues, if necessary, the colleagues from the Department of Vascular Surgery are able to perform either a bypass or to perform a dilatation and stenting of an artery. And let me start with an example, a case that came to us in May this year. This patient had diabetes mellitus, had also a diabetic polyneuropathy, had good pulses. So we directly started with an antibiotic treatment. And as you can see on the right side, he had definitely an osteomyelitis. So we used the ulcer the patient already had to get those parts of the bone out. And you can see on the right, after 2 weeks of antibiotic treatment and also local treatment with microsurgery and also with antiseptic bandages, you can see the result compared on the left to the way the patient came to our hospital. And if we look also at the X-ray result of our treatment on the left, admittance, and on the right, dismissal, you can see that we were able to take away quite a lot of the bone. Of course, we not always have such a nice cutoff like a surgeon has, but obviously this is not necessarily a problem on long term. What's very important when the patient is leaving our hospital to have an appropriate footwear for at home in order not to get again the ulcer. And this is what the patient that I presented you got home with. Of course, we work with a lot of temporary shoe wears, like for instance, air casts, as you can see here. We also do a lot of total contact casts by ourselves. And in some special cases, when the static of the foot is especially difficult, we make for our patients, we call it Baumgart orthesis. This is, if you want a more sophisticated total contact cast, which is done by our orthopedic shoemakers, they need around 1 week to make it, especially for the patient and also for the problems that the patient has. This is the week where the patients still are in the hospital. So at dismissal, they receive their orthesis. We also see the patients afterwards on a regularly basis in our outpatient unit. Let me now present you another case. This was a type 1 diabetic subject with diabetes for more than 40 years. He had also a diabetic polyneuropathy, a peripheral artery disease. He came to our hospital in June this year, but he had an ulceration at the 4th toe already in January 2021. And the therapy was in the beginning done by the general physician who referred him in May to another hospital where the colleagues found out that he has a stenosis of the superficial femoral artery and also of the popliteal artery. They performed a dilatation and also a stenting, but nevertheless, the ulcer did not heal. So the patient was referred to us for further investigation and treatment. And if you look at the X-ray, you can see clearly that the patient has a bone destruction and probably here is also an osteomyelitis. We started as an antibiotic treatment first according to the wound smear with trimethoprim, sulfamethoxazole, which is quite nephrotoxic. That's why we were not happy about a long-term treatment. And afterwards, when the results from the bone microbiology came, we were able to switch him to cephalexin. And this was very good because usually we treat our patients with osteomyelitis in total for 6 weeks orally with antibiotic or alternatively for 2 weeks intravenously. We started in this patient also with a daily antiseptic treatment, local treatment with povidone iodine, and did also an investigation of his arteries. And as you can see here, he had unfortunately a closure of the superficial femoral artery with a good collateralization and refill of the arteria poplitea in the distal segment, and also the lower limb was quite well vascularized by anterior tibial artery and also an fibular artery. So we decided in this case, together with our colleagues from the vascular surgery, to perform a bypass, which was a popliteal, a femoropopliteal bypass. And in the end, the ankle brachial index increased in this patient from 0.5 before the bypass to 1.0. And also clinically, there was clear that the vascularization improved. And we started afterwards the minimal invasive local treatment with, as I have shown you in the small film. And you can see on the left, again, the photo at the admission of the patient, and around 2 weeks later, the result of our local treatment. Looking at the X-ray, again, on the left is the first X-ray at admission, and on the right, you can see how the toe and also the bone developed after our local minimal invasive treatment. We dismiss the patient also with an appropriate shoe wear, as you can see here in this picture. And we like very much such temporary shoes, because here you have the possibility to change the sole there where the ulcer is. And this way you can also very nicely can influence the pressure or the lack of pressure of the patient. And we usually ask patients to wear their shoes until the ulcer is closed and 6 weeks after. And this patient was dismissed with a simple local treatment with polyurethane foam. Shortly, I would like to show you another case of a patient with gout, and he had, because of hyperuricemia, and he had also, because of this gout destruction of joints, he had a quite pronounced destruction. You can see here also this uremia tophis. This is how the two toes looked at the beginning. Here you can also clearly see that we have bone contact. The X-ray was not even that clear if you consider the quite massive clinical picture that we had. And this changed a little bit during the treatment, because we were able to remove some of the bone that was also destroyed by the infection. And let me show you just clinically how the two toes on the left and on the right were. On the left, you can see at admittance and at dismissals around 3 weeks later, you can see that the morphology and also the local infection signs were clearly a gradient on the left side and also on the right side. And I can tell you now that those ulcers healed in the meantime. Now I would like to show you a case that was quite dramatical. And this was a quite young patient, 69 years old, with type 2 diabetes for about 24 years, with a pronounced diabetic polyneuropathy again. And this is a case from the last year. In August 2020, the patient wore street shoes and got a blister. And this blister infected, and this infection was treated afterwards by the general physician for quite a long of time with antibiotic, with local treatment. And from August, when everything started, until October, when he referred to our hospital, you can see here the wound at the moment when we saw the patient for the first time. And what you can see is a pronounced necrosis. And we expected from the very beginning that the wound will be quite deep, which you can see on the X-ray. This is a catheter that we inserted into the wound in order to be able to introduce some disinfectory substances. And you can see how deep this wound was. If you look at the bones, they were not yet that much affected by the infection. We also did angiography in order to see how the vascularization is, and we decided in the end that it's enough for wound healing. You can see in the periphery that at least 2 vessels, the posterior tibial artery and also the arteria fibularis, the fibular artery, were quite good to see, and there was also very nice collateralization in the periphery. So we said, okay, now we can do the surgery, which was done by our orthopedic colleagues. And this is a picture quite soon after the surgery took place, and you can already see that it does not look very well. There are some areas which are avital. You can see that there is no granulation, and that the entire wound is pretty dry. So we treated the patient with antiseptic treatment. We also treated him with intravenous antibiotic therapy, but unfortunately the progression was not positive. And you can see here, so the operation was on the 27th of October last year. This is around 2 weeks later, and you can see that some areas have a progression of granulation, but some other areas develop necrosis. And it was extremely difficult to treat the infection in this patient. So unfortunately, we had to do a few days later transmetatarsal forefoot amputation, followed by a vacuum therapy for 14 days. And again, some parts of the wound showed a very good granulation. Some other parts, again, were quite avital, or even were covered by necrosis. We tried to operate those small necroses at bedside, and this is how the wound looked at the end of December, when the patient was dismissed. Of course, he had at home also a care service that changed the bandages every day, and we were able to see this patient every 6 weeks in our outpatient unit. And the development was good. This is the wound at the end of March 2021, and you can see a good granulation. But 2 months later, this is already in May, you can see that the wound became much smaller. Nevertheless, what we have is this part of the wound that would very, very slowly cover. That's why we decided in June this year to perform a skin grafting followed by a vacuum therapy for more than 20 days. And indeed, there was a good evolution of this wound. You can see here that part of this grafting was also vital, and we hope that over time this new skin will cover the entire wound. One of the most important problems that we had to solve is how to release this patient so that he is able to do some steps at home, not too much. This was something that we also told the patient. It's very important not to walk, but nevertheless, he should have a certain mobility. And this is what we prepared for him, the so-called Baumgart orthesis. And the point here is to try to relieve the pressure from the sole of the foot of the patient to the lower limb. And it worked until now very nicely, and we hope that in a few months we will be able to show you pictures that show a complete closure of this wound. Now, of course, what we do is we try, even dramatic cases, we try to find a solution from them. We try to avoid major amputations, because this means not only for the patient, but also for the society, a great burden. We try to avoid even minor amputations, because some of them change the stability of the foot. They have also a negative psychological impact on the patient. And that's why our minimal invasive treatments, where in the end you can even preserve, for instance, one toe which has no bone, but the toe is still there, has a certain importance also for the stability, but has a major psychological importance for the patient. Nevertheless, there are some cases when we can just have to let go. And it's very important to take the decision very, very correctly. And this is, as many of you know, not an easy decision. Let me show you in the end a case where we decided to perform more or less semi-conservative therapy. This is an old lady, 90 years old, with heart failure, with chronic kidney disease, peripheral artery disease, neuropathy, basically everything that we are afraid of when we have to treat a diabetic foot syndrome. And this lady had necrosis of 2 of her toes, which was longer lasting, but progressed quite fast during the last weeks. That's why when she arrived at our clinic, even though we did not have a very pronounced infection, we started an antibiotic therapy. And of course, we wanted to see how the vessels are in order to stop the progression of the ischemia and of the necrosis. And even though you can see in the X-ray that there is some bone destruction, we first did the angiography and then to the decision. And the angiography showed that there were several stenosis on the superficial femoral artery, which we decided to dilate, because in the periphery, even though some for instance, the tibial anterior artery was closed, there was a good collateralization. And that's why our angiologist did dilatation of the femoral artery and also part of the popliteal artery. And from clinical point of view afterwards, the vascularization proved to be better, and at least we had no progression of the ischemia. Nevertheless, we also discussed with the patient, we discussed also with the family of her, and we told them that the big problem, if we do now a surgical intervention and an amputation of the 2 toes, we will have there an open wound, which is not clear how fast it will heal, if it will heal, and that this might be a major problem if an infection of the forefoot occurs. And that's why we decided together to treat her conservatively. That means we dismissed her with an antiseptic treatment. On long term, she also was given or was organized a service that came every day to her in order to change the bandages. And she also got from us a very simple temporary shoe, just in order to be able to make some steps within her home, because especially in old people, it's extremely important that they still remain mobile as much as possible. And with this, I would like to thank you for your attention, and I am open for questions. Thank you very much.